I think your question was with regard to how many COVID patients have been treated in private facilities. And then you also needed to know in the public facilities, those that had underlying conditions. Am I correct? The second part of your question.
Yeah, those in public facilities who have been in ICU.
Okay, we can start with that. Patients in private facilities, we have the data. DJ?
No, we can share
DG
later.
will respond to that, as well as those in the public facilities that ended up in ICU. We had a question from NTV. A study you mentioned came out of Cambridge, stating that Kenyans are 78% of our cases are asymptomatic. Well, we do have a researcher from Cambridge here. I think I will at some point ask him to comment on that, because there are two questions regarding Cambridge. One is this one on the asymptomatic rate, and the other one is on the seroprevalence rates. We'll comment on that as well. Why is recovery in Kenya low compared to other places such as South Africa? The DG will expound on this, but I would think that we need to be very clear about what we are comparing here in terms of recoveries. Remember that recoveries are, as we move along this journey, we are admitting people as well as releasing people as we move along. So it depends upon what, which part of that pathway that one is looking at in order to get those numbers in terms of recoveries. I would say certainly that we have a fairly good recovery rate compared to most of the other countries that we have seen that have been hit by this virus. I would say that our recovery is fairly good, generally between 30 to 50%, depending upon what time you look at those recoveries. But DG will talk more to this issue of recovery. You mentioned also about medical students and whether there is a need for medical students to continue their internship. We're at a time of a pandemic. Remember, when a medical student is undertaking internship, that is the student's introduction now to really develop oneself to become an independent doctor. It is practical training. There is no reason why these students should not be deployed out there to one, enhance their learning experience, and two, to also bolster the healthcare workers that we need there. For all practical purposes, these medical interns are part of the healthcare workers. And so we don't see any reason why we need to prevent them from being out there in the health facilities and the wards, helping the other healthcare workers deal with this pandemic. Citizen. Direction for family, that was from Citizen TV, direction. What can we do about families who have COVID deaths and are faced with a lot of problems, including payment of the bill? COVID deaths, of course, have to be treated in a particular way, and we have a protocol for that. And that is for the safety of both the family and the healthcare workers who are handling this COVID death. And I think those protocols are being strictly adhered to. But of course, we understand that these places, families in very difficult circumstances. As a ministry, once we are made aware of any particular situation that might face a particular family because of a COVID death, as a ministry, we take the responsibility to be able to, if it is a public facility, then there is no issue in terms of payment of the costs, because we have said that this is covered by the government. If it is a private facility, we can intervene to ensure that the family is given an arrangement that will be suitable for them to be able to one, undertake the burial and also make payments in line with what their ability is. And we do facilitate that from time to time once we are made aware of those situations. We have also worked with the public, private health sector and impressed upon them that we're under very difficult times and they need to be very considerate when they're dealing with people who will be affected by COVID and end up dying. And I think, I believe that most of them have been responsive to what we have told them. And the second question was on the study by Kemri. I'm aware about that study, and I know that that information has somehow gotten out into the public domain. We were really not ready yet for it to be out there in the public domain. But now that it is there and it has come up, I think it is time to comment on it. This is a study that we commissioned, the ministry, together with Kemri Wellcome Trust. We commissioned to look at the seroprevalence of COVID-19 in our population in a quick way, so that we could get an idea of the numbers of Kenyans who have been exposed to this virus. When we talk about seroprevalence, what we mean is we want to look at people who have developed antibodies to the coronavirus. And working with Kemri, who developed a very specific ELISA test. I won't get into the details of the type of test it is, but it's called an ELISA test, which we demonstrated is specific for COVID-19 and is also sensitive to a very high level. We were able to use this test and collect samples. The quickest way we could get what we think would be a fairly good representation, of course not perfect, of the population is to go to a place where we can get the samples quickly without having to do a lot of field work. And so we went to our national blood transfusion services, who have blood collection points in different parts of the country. We have about 6 regional centers where most of these bloods come. And we collected samples from these 6 regional centers, blood representing, most parts of the country. These blood samples were then tested against that test to determine how many of them actually had antibody and how many were negative. And that is the data that you have seen. And indeed, we have gathered some interesting statistics out of this study. What the data tells us is that if we look at those places where we had a fairly good number of samples, including county of Mombasa, county of Nairobi, and a couple of other counties, we are able to determine the percent prevalence. In other words, in every 100 people in that county, how many actually have this antibody. And I can tell you, and I'll have the researcher talk a little bit more about that, but we have some very interesting data. For instance, in Nairobi, we found that almost over 12% of the population of Nairobi seem to have been exposed to this virus. Remember, we are using a small sample and then extrapolating. So using this percentage, we then are able to look at, in the entire population of Nairobi County, for example, the 3 or 4 million, how many people would this translate to having been exposed to this virus? And the figure works out to almost over 500,000 people in Nairobi could possibly have been exposed to the virus and are already carrying antibody. This information is extremely important for us because it gives us an idea of how the virus has permeated the community and what the level of transmission is. Of course, as you know, the test that we do, the RT-PCR test, could not be able to give us this kind of data. Because of the way in which we are targeting this test, most of it is targeted in the sense that we identify positives, we follow them, we do the contact tracing and so on, and at some point we also do a little bit of target testing in certain areas. So this information is extremely useful, and it is information that will feed into our modeling projections to be able to give us now more real data to work with and perhaps improve the predictions that our models are likely to make. I have to say that, one, the sample size is okay, fairly small. Two, it may not be perfectly representative of the country, because these are samples from blood donors. We know blood donor samples, particularly at this time of the pandemic, are biased in a way, because most of the samples that we are getting right now in the blood donor bank is people who are donating blood for their relatives who may require blood transfusion. And when that is not the case, even then our blood donation mostly comes from volunteers in the younger age groups, school children going, university students, and so on. So in that sense, the sample may not be accurately representative of our population and the distribution within our population, but we are continuing to build up on their samples. We also have other work streams that we are going to look at that will improve that representation, so that we have data that is much more stronger in terms of its reliability. I will have Dr. Baraza respond to that, I think, after the DG has also responded to the questions that have been directed to us. Finally, the question from citizen was on COVID-19 test kits. How many have been approved in the country? I would want to restrict it to the gold standard test that we are doing right now, which is the real-time PCR test, or the nucleic acid-based test. I believe we have about 5 or 6, yes, approximately 5 or 6 that we have approved. And we know where these tests are being conducted. We are also aware that there are reports out there of discrepancies in results coming from different labs. Yesterday I talked at length about that. There could be a number of reasons why tests there would be discrepancy in the results between different labs. From all the way from the supply chain, the point where the sample is collected and how it ends up in the lab and how it is processed, to differences in machines and the sensitivity of the machines or the setting of the machines. And the way to address these things is that we have both an internal quality assurance program as well as an external quality assurance program. Particularly the external quality assurance program is one that compares results from labs of samples that we already know their state, and then we share it with labs and we see what they return to us. And then we can be able to detect where there are problems and work with those labs to try to clear up those problems.